Thank you, Dr. Pedley. And to everyone in the audience, good afternoon, greetings and salutations. I'm a clinical neurologist. I work at Columbia University in New York, and this is a privilege and a unique honor for me, a career highlight, to be here and to be able to share some of this afternoon with you. I must thank Mr. Vinu Srinivasan for his hospitality, his leadership, his vision, and also Professor E.S. Krishnamurthy, who executes that vision and curates it so perfectly. In the next few minutes, my colleagues and I will explore and share with you some new neurological technologies to advance the treatment of psychiatric and neurological illnesses with the hope of relieving the burden of human suffering. These are my disclosures, none and none. So my talk concerns the application of technology, chiefly deep brain stimulation, to disorders of the basal ganglia. The basal ganglia, as we know, is an elaboration of highly interconnected neural tissue that governs many aspects of what it is to be a human: locomotion, balance, mentation, cognition, behavior, all of this wrapped up in the mysterious circuitry of the basal ganglia. Located deep within the brain, it is not easily accessible to treatments. It is also the morbid home of many of the most famous and important illnesses, such as Parkinson's disease, essential tremor, Huntington's disease, Tourette syndrome, dystonia. They're all in there somewhere. Deep brain stimulation therapy is a breakthrough, the most exciting therapeutic breakthrough in Parkinson's disease that has occurred in the past quarter century. The technology can be used for essential tremor, epilepsy, dystonia, obsessive compulsive disorder, and there are many ongoing research initiatives to establish better and more applications, such as pain syndromes, depression. We'll hear a lot about depression because that is the seminal work of Dr. Mayberg. Cluster headache, chronic pain, obesity, and other conditions. It all began with a surgical accident in 1953 when New York neurosurgeon Irving Cooper was operating on a patient with Parkinson's disease. He wasn't operating for the Parkinson's, but for some other cause, and he inadvertently ligated the anterior choroidal artery, causing an infarct in the territory of the anterior choroidal artery on one side. This is the territory. And I don't know if I have a cursor, but at any rate, the supply of this artery includes the medial globus pallidus, parts of the internal capsule, and the point of the story is that the patient woke up after the surgery and his tremor was relieved. We are often presented with unusual things in life, but it takes an astute observer to recognize the power of an observation and translate it into further ideas and action and research, and that happened here. Russell Myers, another American neurosurgeon, recognized that this was a critical observation because it allowed the placement of a lesion in the basal ganglia that could help the symptoms of basal ganglia disease without interfering with the pyramidal system, the corticospinal tract. Therefore, he could put a lesion in the basal ganglia and not cause a hemiparesis, and yet relieve the unwanted extrapyramidal symptoms. This is, in my opinion, one of the most important observations in all of neurology. It revealed the way the brain worked in a way that occurred to the great epileptologists who created their homunculus maps. Parkinson's disease, as we know, is a, is there a cursor, by the way? Can I point or? Button. Oh, sorry. Ha, sorry about that. We'll just work through it. But
some
cursor.
pointed to
Okay, and I pointed at
green.
I pointed at the screen, don't I? So this is the pathophysiology and clinical elements of Parkinson's displayed here.
light won't hit the glass screen.
Oh,
That may not work.
that's all right. Down here?
You could do something like this. Oh,
That's
there's nothing at all.
There we go. That's all right. At any rate, on the left is the normal brain, and on the right, a Parkinson's disease brain, and you can see the depigmentation of the substantia nigra. It is not as black in the Parkinson patients because those pigmented cells have died, and as a result, their projections, the nigrostriatal pathway, atrophies and becomes non-functional, and this gives rise to the cardinal motor symptoms of Parkinson's disease, including tremor, rigidity, bradykinesia, postural instability, and gait freezing. But Parkinson's disease is a multi-system illness if there ever were one. It is the second most common cause of dementia after Alzheimer. Parkinson patients suffer from progressive cognitive impairment, hallucinations, psychosis. They're subject to every variety of psychiatric illness, anxiety, depression, obsessive compulsive disorder. Apathy is a tremendously disabling symptom. We'll hear more about that later. They suffer from sleep disturbances, autonomic disturbances, including hypotension, bladder impairment, bowel impairment. All of this is part of Parkinson's disease. The treatment for Parkinson's disease is really based on one simple principle: replace the missing levodopa and dopamine. And it works incredibly effectively at the beginning in many patients, but after 5 years or more, at least 50% of patients develop this clinical problem, and this is the clinical problem for which deep brain stimulation is tailored. They still experience a reversal of their akinesia and rigidity when they take levodopa, but it lasts shorter and shorter. And as a result, they need to take their medication every 4 hours, then every 3 hours, every 2 hours. The other part of the problem is that when they take their medication, they are relieved of their akinesia and rigidity, but then they develop chorea, generalized chorea. So their immobility is replaced by twisting and writhing movements. And these both occur, the on-off motor fluctuations and the dyskinesias, in the same person. And they spend their whole day fluctuating like a roller coaster. They are akinetic, they take their medication, they're mobile, and their mobility is corrupted by generalized chorea. Oh. Now we have it. And so this is a day in the life of a Parkinson patient with the doses of levodopa on the bottom, and they go through these cycles of dyskinesias. They plunge down into the trough of akinesia, back up for the next dose, and all day long. And as you can appreciate, this cannot be solved by pharmacological intervention. If you treat the dyskinesias by reducing the levodopa stimulation, the off spells get worse and vice versa. So this system can be interrupted by the surgical interventions described. Deep brain stimulation is pictured here. It involves the implantation of electrodes into selected parts of the basal ganglia. These electrodes are At any rate, these electrodes are very reliable, even if my own work with this pointer is not. And you can see that they are implanted in the brain and connected to implantable pulse generators or batteries in the chest. There's an X-ray over there, and you can see the electrodes. This is a simple skull film, but there are the electrodes. And here they are in this coronal MRI. And the electrodes have these contacts numbered 0, 1, 2, and 3 on each side. The electrodes are dark, the contacts are there, and through these ring contacts we can stimulate the surrounding brain tissue and as such depolarize it and shut it down to some degree. This is a monopolar electrode with a ring contact. You can imagine placing an electrode into this incredibly complicated network. Where it ends up precisely is not clear. Is it closer to an axon, a dendrite, a cell body, a synapse even? It is so incredibly complex that the electrical effects can only be understood by further study, but the clinical effects are thankfully easier to modulate. We can stop tremor, we can improve rigidity in real time. What we think it does is stop the brain cells from firing, neuronal inhibition, and thereby shift the entire output of the system in a way that's more physiological. This is the microscopic event, but there's the microscopic event, but the physical event is the reduction of tremor. This is a schema of the basal ganglia. We are not going to go through this, but ultimately the output of the basal ganglia in a patient with Parkinson's disease is abnormal. It's meant to be depicted by this large arrow here. This is an excessive excitation that is measured in the brains of patients with Parkinson's and can be corrected by placing a lesion or a stimulator nearby and ultimately affecting the output of the basal ganglia, which always comes through the thalamus. This is a traffic light, multiple traffic lights, and this is a metaphor for the basal ganglia, on and off signals. Just imagine placing an electrode right in the middle of that and determine what effects are occurring. The surgery itself involves the accurate implantation of electrodes done through various hardware manipulations. This is an operating room. This is the frame. We'll hear more about this later because I'm followed by two neurosurgeons. And the trajectory is carefully plotted, and the tip of the electrode is targeted very specifically.
Okay.
This is a gentleman who has undergone deep brain stimulation. He previously had dyskinesia off, and we see him here off medication, off stimulation. We will turn this on shortly. He's akinetic, he can't get up, he can hardly move, and the left stimulator is about to turn on.
Okay, you may feel a little tingle.
There it goes. And so we will see that the right hand is moving and it has stopped trembling. And this is in real time, this is how it happens. Now we turn on the right stimulator, hoping to help the left side of his body.
There it goes on.
What do you feel, Mr. Bed? Can you tap it like this? Make it big and wide.
This is one of the most extraordinary events in medicine.
Can you try that with your left hand?
The only thing that happened was a switch was turned on. An electric current was applied, and a trembling akinetic person is animated. To me, this is a miracle, although it is an everyday miracle with some patients. He can barely walk. He's trying to get his arms to move, but his feet are frozen. He can't advance either foot. Freezing. But there he goes. And this was done some years ago, and he continues to do well. I continue to follow him.
Yes,
How do you feel right now?
I'm much better.
Much better? Okay. We see your tremor has stopped.
His posture is better.
Can you
His
place both hands in front?
animation is better. You can see from his facial expression. He has been transformed
Can
by
you go
this.
like this with both hands? Great.
His head is moving
Can you
now a
take
little
your
bit.
right
He's
foot and
developing
stamp
those
the floor?
dyskinesias, but only to that extent.
Excellent. Can you try that with the left foot? Okay. Cross your arms on your chest and stand up directly. You knew what to do. Okay. How does your walking feel right now?
You see his arm swing? It's a little
Okay,
excessive.
Good for you.
That's okay, but it's a little bit of a dyskinesia induced by the DBS just there. I think we did this. I'm going to move ahead. This may be a follow-up. Let's just go ahead. When this was first reported in the New England Journal of Medicine by Benabid and his colleagues in Grenoble, France, it was an astounding article. Only 20 patients, but it was the first time this was shown to work. 20 patients is not a lot, but I think you only need one patient to determine if it works or not, as we've just seen. An N of 1 is so convincing sometimes. At any rate, after establishing that this was effective, the question became, how long does it last? What does it do in the long term? Is it better than the best medical therapy? And this article, the same group published some years later, randomizing patients with advanced Parkinson's to either best medical therapy, which is the only alternative, continue with your medication, or deep brain stimulation. And it's not a surprise that the DBS group did much better in every measure, but also in measures of quality of life, which is listed in the chart down below, a quality of life scale. So who should consider deep brain stimulation? The ideal candidate is a typical patient with Parkinson's disease, in contrast to an atypical patient who does not have Parkinson's disease, maybe one of the lookalikes. They must still respond to levodopa, even if that response is temporary. Those who do not respond to levodopa will not respond to the deep brain stimulation. Dyskinesias almost uniformly improve, and a patient with dyskinesias, maybe a younger patient who also has the wearing off spells, these are all the ideal characteristics of a patient who will benefit from this therapy. It is certainly not for everybody. Those who have postural instability or severe freezing, falling, dementia, depression, other complications of Parkinson's for which levodopa does not work are not candidates for deep brain stimulation. And to insert electrodes into the brain of such an individual is only troublesome. What we do at Columbia is a very careful appraisal of the patient with a multidisciplinary group that includes the neuropsychologist, the electrophysiologist who can measure tremor and other aspects, the neurosurgeon, of course, and the support faculty. The key thing is they must have Parkinson's disease, and there are no truly reliable tests for that, so the diagnosis depends on an accurate clinical appraisal. When should a patient undergo DBS? I mean, that's a very important question in the field. It is not a neuroprotective treatment. It doesn't halt the progression of the illness. If it did, everybody would have it at the beginning, but it doesn't do that. It's fundamentally a treatment for the complications of levodopa therapy. There is a move within the field to implant electrodes earlier and earlier in the course of the illness, because waiting too long, even if the patient may at one point have been an ideal candidate, is a problem because the disease continues to advance and they're more likely to have developed falling or apathy or dementia. These problems, if they develop, sometimes can undercut any benefit from any treatment and are sometimes worse than the motor symptoms of the illness. The treatment has to be very goal-directed. What bothers you the most? Is it the tremor? Is it the dyskinesias? That's what we target. And patients may have an unrealistic view because the surgery and its results are so dramatic, they're extraordinary, that it can be extraordinarily inflated in terms of hope. And so we have to be very careful, and patient education is part of this. The treatment doesn't stop with the deep brain stimulation. It continues to include, in many patients, many other modalities, such as medications and relaxation and sleep management, treatment of psychiatric illness. It's a multidisciplinary, fully comprehensive approach that continues. Some symptoms do not respond either to levodopa or DBS, and these remain very important unmet needs that must be the subject of further study. Non-motor fluctuations. We'll hear about that later, but there are patients whose motor symptoms fluctuate, but in parallel they have emotional symptoms that also fluctuate with each dose of levodopa. These symptoms can be affective, that's to say anxiety, depression, apathy, pain, autonomic. There's different types of non-motor fluctuations, and it's very important to be aware of them. Hypophonia and tachyphemia. Tachyphemia is that rapid speech, that stuttering speech. Very hard to fix that. I can tell you more about that later. There are other technologies for that, including immediate feedback to the patient's own ear. The flexion deformity of Parkinson's is not well understood, even though it's widely recognized. This is an old picture from 1882. Charcot's group noted the follow-up after 5 years of a woman who became increasingly camptocormic and stooped over. Very hard to treat this. It's not orthopedic. It is a Parkinson-related, perhaps dystonia, perhaps a failure of postural fixation. Apathy, dementia, very, very important and devastating problems, not treatable by DBS. There are some new approaches and future advances, including expanded applications. I'll very briefly show you a number of these other technologies because the technologies are advancing and developing. In terms of newer indications, this is a clinical trial of patients who underwent DBS with early motor complications within 4 years, and they have done extremely well. And in terms of the long-term follow-up, many of the effects are durable, including tremor, control, rigidity, bradykinesia. And if you can implant safely and early, it spares the patient many years of medication adjustments. One goal of DBS therapy in some cases is to reduce medications that may be causing adverse effects such as psychosis. These are just other technical advances. The leads are becoming more complex. They're becoming segmented so that one can direct the current in different ways to optimize therapy and minimize side effects. These are just cartoons of electrical directional stimulation. The closed loop stimulation is important because currently we just exert a force, an electrical force, on neurons. But what if the result of that could be fed back to the input itself? And that would be a loop, a closed loop. And the feedback could be electrical, some sensing device, or even peripheral, a patient wearing an accelerometer on a finger, and the tremor reduction is fed back to the stimulator. So that is coming. One can imagine a day when the entire system, including a sensing and closed-loop feedback, is all implantable. The sensor, as such, does not yet exist. The batteries are getting smaller. Someday they'll be implanted in the skull itself. They're already doing this for epilepsy. And I'll give a penultimate word to James Parkinson himself, who described in this masterpiece of medical writing most of the symptoms of Parkinson's disease that he observed in patients. He was an astute observer. He got all of it, including the autonomic, the excessive saliva. And he wrote that there, this is over 200 years ago, appears to be sufficient reason for hoping that some remedial process may ere long be discovered. So that's James Parkinson's. I don't know how I'm doing for time, but if you have a moment to see two extraordinary videos, I will show you two additional applications of deep brain stimulation. The first for Tourette syndrome. I won't describe the disorder, but it...
Okay, right. I want you to see if you can, for just a moment, suppress the tics.
This is continuous. Tic status. Phonic tics, motor tics. The target for the electrodes in such an individual are numerous. He underwent placement of bilateral thalamic electrodes, but there are many other targets. And the circuitry of this is not as well worked out as it is for Parkinson's disease and the other motor disorders.
This is March 18th.
You see he has a new haircut. He had electrodes placed, and the surgeon takes these sorts of precautionary...
Week or so?
Yeah, about a week.
Okay.
He still
Is it
has tics,
mild,
right? He
moderate,
blinks.
Severe?
Mild.
Okay.
Motor tics of the face, but minor. Little fidgety.
Hold your hands out. Okay. Rest your hands down. I want you to see if you can suppress them, okay? Just for the next couple moments.
Remember when he used to videotape me, it used to make me more nervous and I would be taking like non-stop.
Yep. So today's a big day. Let's tell everybody why.
It's my birthday,
How old are you now?
17th.
Okay. And how are the tics doing?
Great. Barely any.
So he has been relieved of this extraordinary experience of continual tics.
The camera.
This is a different condition of the basal ganglia: dystonia, involuntary twisting, sustained postures, multiple causes of dystonia. The patient here has pure dystonia caused by a gene. In fact, it's DYT1 gene mutation, most common we see in New York, and that mutation was described at Columbia by Dr. Bressman and colleagues, but let's roll it. So there she is. Her dystonia involves, as you can see, the trunk. It's an axial dystonia. Began at age 14, she's now 28.
Was one of our first
my
patients.
colleague,
Dr.
Dr.
McCann implanted electrodes deep into PJ's brain and connected them
You see the
with
electrode?
wires to
That's a
these
cartoon.
implantable batteries in the chest wall. Waited.
Started walking on crutches. By Labor Day of that year, I took my first steps on my way upstate. I'll never forget it, with my father and my kids. We were at an ice cream stand, and I walked, and it was unbelievable. And ever since, no turning back. Thanks to the hospital and all the doctors, here I am. And now I actually have a normal life.
This is otherwise untreatable. This was the only treatment for PJ. Medications for dystonia, if you've had experience, are not very effective. They cause side effects. This is extraordinary, and we don't exactly understand why dystonia does what it does or how it can be improved, but it is helped by deep brain stimulation in the globus pallidus. Ooh. Just as a closing remark here, some of these are the most devastating conditions to afflict people, and these therapies are extraordinarily powerful. This is new for neurology. Neurology was once the repository of untreatable and intractable illness, but it is changing in all fields, not just the movement disorders, but in oncology, brain tumors, for example. As such, this is one of the most exciting times to follow the story and to be a neurologist. And we learn from our patients, and we're grateful to contribute, which of course is the underlying philosophy of this entire symposium. Thank you very much for your attention.
Thank you, sir, for a nice presentation. The paper is open for discussion and presentation. He'll be happy to answer your questions. Sir, you be there. So that any questions?
This is done by embolization or through injections. Which you have to do?
You said anterior choroidal?
Occlusion procedure.
Well, it's not done as a therapeutic procedure. It was an accident. No one really does that anymore. Although they had placed lesions, they had replicated the effect, but lesion-based surgery is virtually obsolete, except for now newer applications such as focused ultrasound that you may have heard. The accuracy is pinpointed, but you know, this whole field began before there was any neuroimaging. The neurosurgeons figured all this out, including the wiring of the basal ganglia, on the basis of lesions that they placed. It is a remarkable story.
Yeah.
Have you tested the neuropsychological effect of deep brain stimulation, sir?
The neuropsychological effects of deep brain stimulation. Very interesting question and very crucial to the way we use and apply this. The world expert in this is speaking later this afternoon, Helen Mayberg. But in general, patients who have some cognitive impairment may not do as well. To get the electrodes on target, they have to pass through the frontal lobe. And many of the classic features of Parkinson dementia, executive problems, constructional apraxia, naming, sequencing, all of this is part of a subcortical frontal dementia. And it won't improve with DBS, it may get worse. In the long term, however, it is generally well tolerated in a patient whose baseline is adequate, and neuropsychological testing is done at baseline and in follow-up.
Okay, sir. Because I have seen the symptom improvement in your case, 2 cases. I just curious about their neuropsychological aspects. Have you tested in those?
Well, the patients that we've shown,
Yeah, sure.
They are some years out from their surgery. They've had no cognitive decline that we've been able to measure or that is apparent clinically. But it, at least in the Parkinson gentleman, is possibly going to happen one day. The point incidence of dementia in Parkinson's is about 80%. So people developing Parkinson's, 80% of them will develop some cognitive impairment in the future. It's not a minor proportion.
What about apomorphine treatment? Apomorphine.
Apomorphine, that is a dopamine drug. It's a dopamine agonist. Its property is that it works instantly, almost immediately. So it is used as a rescue therapy in a patient who is akinetic, unable to walk or move. They inject themselves with apomorphine, a pre-selected syringe, but of course they have to be mobile enough to do the injection or have a person administer it. In England, this was given on a continuous infusion, 24 hours a day apomorphine, in the hopes that they would never go into the off akinetic state. But as you can imagine, what happened instead was dyskinesias. So it induces dyskinesias, and so it's not a practical treatment outside of a rescue therapy, an immediate rescue therapy. It works in 30 seconds.
Sir, this deep brain stimulation help to arrest the progress of Guillain-Barré syndrome, viral conditions like this?
Does it tend to arrest the progress of?
Guillain-Barré syndrome, which is basically a viral condition which develops, it affects the nervous system, neuromuscular system. Does this help to arrest it, arrest the progress?
Oh, no, it does not do that, nor does it help the motor symptoms of that disorder.
Thank you for the wonderful presentation. I run a support group for people affected by Parkinson's in Chennai. Two big questions are always about deep brain stimulation, and we keep giving them a lot of counseling on it. But here, some of the hospitals or medical practitioners are a little aggressive in pushing for a DBS as a solution for Parkinson's. So if I have to counsel my members, what are the first topmost things that I should tell my members to ask their doctor about DBS? Because a lot of older gentlemen affected over 80, they have gotten DBS done and it has adversely affected their quality of life. On the other hand, we have had some very good improvements with DBS as well. So as a cautionary question, what should they be asking their doctor? Top 2 or 3 questions.
It's a very important question, and thank you for your work with these patients. There's a lot of unrealistic thinking that goes into this, but basically this is a treatment for dyskinesias and wearing off. You mentioned an 80-year-old gentleman. That individual has had Parkinson's for probably more than a decade, and even though they're applying this therapy earlier and earlier, he is more likely to develop longer-term complications such as falling, freezing, retropulsion, cognitive psych. So these will not improve. The patients have to be focused on motor symptoms, dyskinesias, and in some cases, severe tremors. Those motor symptoms are really the only effective issues that can be dealt with by DBS. Otherwise, the patient has electrodes and there's risks of infection and it becomes so complicated, I would steer them away from that.
Is there any connection between a stroke and Parkinson's?
No direct connection other than the accidental stroke that was occasioned so many years ago. But vascular Parkinsonism, which is thought to be multiple little strokes affecting the basal ganglia and beyond, can cause a Parkinson's syndrome. But otherwise, we have an autopsy program at Columbia. We have an enormous brain bank, and we wonder sometimes if a patient who has died with Parkinson's really had Parkinson's. Sometimes they have a little bit of vascular disease. They've had diabetes, hypertension, but it's incidental. So there's no direct causal association.
Would you consider a patient above, say, approaching 80 with DBS?
Of course, if they were free of the exclusions, if they were the right mix of symptoms that are the ones that respond to DBS. Our oldest patient at Columbia was 87 when he had his operation. He had a major tremors, and the tremors, he was a famous architect engineer, and after he had his DBS, his tremors went away. He began to lecture around and around the world on architecture, but also his own DBS experience. So age itself is not an exclusion.
This patient I am mentioning is a total invalid in bed, but conscious. Will DBS help?
It will not. It'll make him worse.
Thank you.
Sorry to say.
Is there any role for artificial intelligence in pinpointing the onset of dystonia and Parkinson's patients?
Artificial intelligence?
Yes, of course. Is there any role for pinpointing onset of dystonia in Parkinson's disease?
I don't think that's the way to do it. Some dystonia is the result of a gene, so genetic testing may be predictive of future dystonia. It often runs in families. In Parkinson's disease, many genes were identified in the past 20 years. That's a big story. But in terms of artificial intelligence, I think it...
Yeah.
Did it matter if your patients were on long-acting Stimulate or the COMT? Did that produce less of
So the question was about does a patient's medication treatment have an impact on the...
Does it delay the need for DBS if they got the long-acting forms of Stimulate and the COMT inhibitors?
The need for DBS, it's always elective, and it focuses on the complications of certain types of treatment. If a patient is on COMT inhibitors and other medications, as we know, or as I believe, there has yet to be any medication that is truly neuroprotective. But the patients on long-acting levodopa, they're on it because they already are developing wearing off motor fluctuations. And at some point, they may have more severe off spells, more frequent off spells, increased doses of medications and dyskinesias. A cycle could begin over the next several years. One doesn't want to subject anyone to brain surgery unnecessarily, but there comes a time when a patient decides, my life is imprisoned within a drug schedule. I'm just locked in these cycles of wearing off and motor fluctuations. And at that point, it's a quality of life decision. Patients consider the DBS. It's not a doctor that says, you need DBS. We shouldn't ever do that. It's the patient and the family make this decision, an informed decision.
Is Pacitin contraindicated?
Is what contraindicated?
Dopamine.
Oh, trihexyphenidyl?
Yeah.
An anticholinergic drug. Actually, the first treatment for Parkinson's, that's what Charcot gave. He gave belladonna, anticholinergic, and it helped tremor. But it also causes confusion and memory impairment, and so I have never given it to patients with Parkinson's disease. It is one of the standard beginning treatments for dystonia. And certainly no one over 70 can tolerate it anyways. I mean, just too risky for mental side effects.
One of the indications for deep brain stimulation is obsessive compulsive neurosis. What are the clinical criteria you will take into considerations?
The best person in the world to answer that question is speaking later. Obsessive compulsive disorder is infinitely fascinating, and many patients with Tourette's and Parkinson's and other basal ganglia disorders, Huntington's disease, they have OCD behaviors. The circuitry is not as well worked out, and I say no more than that, but it is an area of active investigation.
What about inhaled levodopa?
Levodopa? Inhaled levodopa seems very promising. It's new. It underscores the basic point that all treatments for Parkinson's are based on levodopa. It, like apomorphine, is supposed to be a rescue therapy. So, you just inhale it and you're relieved of akinesia and rigidity. It's a delivery, but it's still the same medication.
Yes. Thank you for...